tools that can be used to assess your IPC national plans in terms of COVID-19, specifically related to health worker infections and ensuring that as we continue to battle COVID-19, we are being very mindful that we are addressing healthcare worker infections as they increase in our region. Next slide. This first presentation is a very brief introduction to what specifically we're going to talk about, and this is what I like to call the toolkit, the IPC toolkit that's used to actually strengthen the capacity of any and all individuals who are involved in IPC activities. WHO AFRO, along with key stakeholders and external partners, work to develop what we call sort of an IPC toolkit. You can see that there are three primary tools that we have provided and we're going to discuss today. One is the national performance of health worker personnel and their associated professions at the national level, which is what we call Tool 3. The second tool that's available for you to use is to do an assessment of potential infection amongst health workers that have occurred at the facility level. And then after an identified case of COVID-19 has been diagnosed in a health worker, utilizing tool 4 to retrospectively or to go back and investigate the potential cause of the exposure at the healthcare facility can be used. We also want to try to understand the role of healthcare worker infections at a community level, and then of course ensure that we have organizational measures in place for systemic implementation in addressing any healthcare worker infections. Next slide. So this is a very brief outline that I'm going to review with you today. We are going to emphasize on the three tools that I talked about for this toolkit. And these three tools are specific, one, right now to COVID-19, but hopefully can be used also going forward after the COVID-19 pandemic to identify other forms of healthcare worker infections within your region or contexts. The first tool I'm going to talk about is the assessment tool that looks at your national COVID-19 policy for healthcare workers. Next slide. This tool is also called Tool 3. When would you want to use Tool 3? Tool 3 essentially is a part of a situational analysis that you can use to further develop an action plan for IPC. It also includes components that are related to monitoring and evaluation to be able to measure the IPC progress that you're having at an overall strategic level over time. Who should use this tool? The National IPC Committee member and principal of those individuals at the Ministry of Health, representatives and stakeholders who are engaged in IPC activities in your country, and different sectors who are engaged in IPC activities. It should be used comprehensively and inclusively with the objective of mind that we want to make sure that we are also striving for IPC to be a continuity service platform, even well after COVID-19 has passed. Next slide. So you may be asking me, Ebeth, how do we use this tool? On this slide, you will see a very brief algorithm that can be used to actually implement this tool successfully. You want to first see if you have a national IPC focal point and or committee designated at your Ministry of Health or otherwise, specifically for IPC implementation. If the answer is yes, then you can continue on and use Tool 3 to conduct your actual national performance appraisal. If the answer is no, then you can designate a national IPC manager, try to go about then assessing and using the tool, and then right after using the tool, making sure that you have the actual strategic plan in place for IPC with actionable items ready for implementation, and then of course reevaluate evaluating with the tool again after you have a little bit more strategic practices and strategies in place. Next slide. The next tool we will be discussing today is Tool 2. Tool 2 is used to assess risks amongst healthcare workers who may have been exposed to COVID-19 whilst in a healthcare facility. You would use this tool when there is a suspicion or a known risk of COVID-19 exposure in a healthcare worker. This tool should be used by specially trained health managers or individuals who have been designated by the national program to complete this tool and to investigate healthcare worker exposures. Again, this should become a part of an exhaustive IPC strategy. Next slide. Similar to Tool 3, there is an algorithm for Tool 2. If you have a suspicious exposure or suspicion of exposure amongst a healthcare worker, you want to do a very quick risk assessment to ensure that if this person needs clinical management, that assistance is provided. By filling out Tool 2, you can very quickly identify if the personnel was exposed or not. If the personnel was not exposed, then no additional measures are required on behalf of the healthcare facility and its administrators. If there is an exposure that was identified by using the risk assessment tool number 2, then taking measures for the exposed individual as well as anyone else who was involved in the exposure should be addressed immediately. Next slide. The third tool that we're going to talk about today is what we call Tool 4. Next slide. This particular tool is actually a case investigation tool. This tool will be used after a confirmed COVID-19 case has been identified amongst a health worker. A specially trained health manager or individual identified by the National IPC Program or Ministry of Health involved in IPC activities should complete this tool. This tool should be used on a case-by-case basis, meaning that this tool, similar to Tool 2, should be used one tool for every exposed case or confirmed case. So you would have, if you have one exposure, you would use one tool for each potential exposure. If you're going to do a case investigation, you would use one tool for each case you want to investigate. Next slide. Tool 4 also has an algorithm. Once a confirmed case within a healthcare personnel has been identified, you want to make sure that you start your investigation to try to assess what was the breakdown in IPC at the healthcare facility to understand where are the challenges so that they can be corrected. You'll use Tool 4 to determine what exactly were the gaps and what was the causes of the exposure to the healthcare worker so that appropriate measures can be taken. Next slide. Last but not least, it's very important that you keep in mind that as you use these tools as a part of your comprehensive COVID-19 strategy, as well as IPC strategy, you keep organizational measures at both a national and subnational level for these tools at the forefront of your mind. Next slide. There are a few administrative measures at the national level we would like to keep in mind as you begin to think about using these tools. You want to make sure that these tools are used systemically as a part of a larger healthcare worker protection program. You want to make sure that individuals who are going to be responsible for completing these tools understand the importance of doing so and why investigations are important for being conducted. You want to make sure that individuals that are completing these tools make sure that there is a correct referral system at each step of the healthcare system. And then once you have identified cases, unfortunately, you want to make sure that measures are put in place at each level of the healthcare system to address any IPC gaps or deficiencies that may have led to the actual healthcare worker exposure in the first place. Next slide. Additionally, you want to make sure that the appointment of a referent or individual who's going to be completing and responsible for these tasks has very close relationships with the healthcare workers and the systems in which they work. You want to make sure that they are closely aligned and linking any integration of these tools with an overall IPC committee. You want to make sure that there is a strong competency model in place, organizational measures in relation to districts or health region to enable referral as soon as possible by the referent in the event that an exposure or confirmed case is identified. Again, it is always very important that in the event of any exposure to hazardous bodily fluids, emergency management protocols are available and are utilized very quickly to ensure that the health worker gets appropriate care. Next slide. So, just to show you, here are the three tools again. We have different platforms for the tools, such that you can see we have the tools available in Excel files, we have the tools available in Word documents, and we also have the tools available being maintained in a dashboard called Kobo. If you click the link that's available here in this slide, I can very briefly show you the actual dashboard and collection tool that can be used in real time. Kobo allows users to capture data offline while in the field, and then once back within internet connection, the data will automatically be transferred via satellite to the Kobo data collection system. This makes it very efficient and user-friendly when you're working in the field and in geographical areas that may not have internet connection or mobile access platforms.
Would you like me to click on the link?
Yes, if you could just click on the link just to show very quickly. Did I lose you? I fear I've lost you.
No, I'm sharing the open Google.
Oh, thank you very much. Perfect, Nancy. Thank you very much. So, in the event that you and the individuals who are responsible for implementing and collecting information within this tool wants to use the Kobo system, you can click on the links that are provided for each of the tools and populate the tool electronically in real time. This can be done on any Android device, and as I mentioned, can be captured in real time off-site at a healthcare facility, irrespective of the internet capabilities at that healthcare facility. I won't go through this individual tool because it will be gone through by Gertrude, I believe, in the next few slides. I just wanted to show you and give you a brief idea of what this platform looks like. If we can go back to the presentation now, I would appreciate it. Thank you, Nancy. So to try to make data collection and the utilization of these tools as easy as possible, we've created multiple ways the data can be collected. As you can see, you can use paper-based tools, Excel tools, and/or the Kobo system. Next slide. Okay, now we have a few questions and answers, and I believe that's the end of this first presentation. Next slide. So next steps. Next slide. The next steps is that you can actually start to look at where you specifically are in terms of the context for your actual country activities related to IPC. If you look at the schematic, the National Policy Assessment, and essentially Tool 3, which I will go through with you in just a few minutes, does an overarching analysis of the sort of national program that's in place for healthcare worker infections related to COVID-19. As a result of the national program and sort of where the program itself is at, you can then assign investigators specifically that will be involved in training and actually starting investigations. You want to also ensure that naturally you have IT capacity if you want to use the COBO system and the ability to engage in in-country specific analysis. And then, of course, complementary to tool 3 are tools 2 and 4. In the event that you implement these tools, you want to ensure that any adaptation of the tools is happening at the country level, that there's country level investigation, and that the analysis is conducted within the Ministry of Health and with the assistance of WHO partners as best to their ability. Next slide. So in terms of the actual information management and actual data analysis and collection processes related to these tools, the specific country responsibilities are providing training for those individuals who are going to be actively collecting data in these tools, knowledge of how to complete them, and then of course strengthening the overall IPC capacity at a national level and within national systems, and making sure that these tools are integrated within an overall national platform. The responsibilities of the regional offices are to ensure that data and analyses associated and collected through WHO IPC focal points is done so in a timely and thorough manner, that updates to the dashboard when needed are done so in a timely manner, and that any sort of new versions of tools that need to be created and or adapted are brought to the attention of the regional office for consideration. Next slide. And then last but not least, in terms of IPC focal individuals and other individuals in the country, here is an IPC Dropbox whereby all of the different tools that also can be identified and utilized. Next slide. And then last but not least, just to give you a more detailed idea of what's in these actual Dropbox tools, you can see within the IPC tool folder, each of the individual tools that we are going to talk about today are located for your use. That completes this first presentation on the summary of the overall slides. And now we will move to tool 3 so that I can present tool 3 to you in further detail for your understanding. Thank you. While Nancy pulls up tool 3, are there any questions regarding the content that I just discussed? If you have a question, feel free to put it in the Q&A folder, and we will, myself and my colleagues will do the best to answer those questions towards the end of this session. Everyone's being a little bit quiet. I get nervous when people get quiet. I know this is a talkative group of people. I know a good many of you. I know people can talk.
Can I say something, Yvette?
Yes, Professor Babakar, please do.
I would like to make a statement about the tool tree. I don't know if it is better I do it now or after your presentation. I don't know. What do you think?
It's up to you, Professor.
Maybe it's better I do it now so you can take it into account during your presentation.
Yes, Professor Babakar, go ahead.
Thank you very much, Yvette. First of all, I would like to say that when a tool is new and has never been used, people should start by testing the tool. The tool free have never been used, and we didn't do a test with this tool. But in the first application in some countries, we experienced some problem of misunderstanding, and they have some confusion about the utilization of the tool free. The reason is in activities in the tool free, we have two kinds of activities. some activities are very specific in healthcare workers' protection, while other activities are non-specific. If you look at the tool, we have 5 components. The 2 first are, the first one is about the IPC program to protect healthcare workers, and the second is multimodal. Where is the second? The second is about a multimodal strategy to prevent healthcare workers' infection. In these 2 components, the activities are not specific for protecting health workers. While in the 3 other components, component 3, 4, and 5, all the activities are really specific on healthcare workers' protection. So my suggestion will be to remove all activities in the component 1 and 2, and the 3 other components, the survey, early screening, testing, and return to work for health workers, and the investigation and confirmed infection. We'll have 3 components. And in these 3 components, you can see that you don't have only the tool 2 and 4. So the national program will not be comprised only of the investigation of the tool, will be comprised also with epidemiological surveillance and a national strategy for screening, for returning to work, etc. But all countries will not have to use all activities proposed, because each country will have to prioritize and to use only what they can do. But I can already give priorities. The first priorities in the national program for health protection, the component 5, investigation and exposure and case confirmed, first priority. The second priority will be the epidemiological surveillance of healthcare workers' infection. And the third priority will be national strategy to manage workers' exposure, infection, and the return to work. So this change will bring us to make also some change about some tools like the guide exposition, but very minimum change in this tool. The guide and the tool, PowerPoint tool also will have the small changes. Yvette, I don't know if you understand well. My French is not good, but it was my statement. Over to you, Yvette.
Yes, thank you, Professor Babakar. Well noted.
There are a few questions from the attendees. I'm wondering whether we'll be taking them now or we wait up until the end of the presentation.
I think let's wait till the end of the presentation if it's okay, Nancy. Let's give everyone an opportunity to see all 3 of the tools, and then they can ask us specific questions about the tools at the end, or not just the tools, but even just the larger national strategy we're trying to really promote to ensure that we have, continuity of IPC services going forward. Is that okay?
Yeah, that's okay.
Okay, we're gonna get through this. Okay, everyone, I'm gonna do an energizer. I feel like everyone's being too quiet. I'm gonna have to energize you. I'm gonna give you some eBeth love. Okay, here we go. Let's talk about tool 3. So as Professor Babakar stated, tool 3 is a higher level tool that really is looking at assessing an overall national COVID-19 protection program for healthcare workers. This tool has been created specifically for the contexts that we in Africa are challenged with in terms of our healthcare system delivery platforms. So this tool is one of the very first tools you would want to use before starting to use tool 2 and tool 4 to be able to have an understanding of where your national program is. If you don't have a national program, that is something that's also good information to have, because then you would want to make sure that you take a few steps back and then talk about and prioritize how you can have the beginnings of a national program or IPC committee within your Ministry of Health. So I'm not sure if what's easier. You can see this tool. This tool is currently being delivered in English because we're English speaking, but one of the things that I wanted to point out is that this tool is available also in French and Portuguese. If you go up to the column D, D1, and you click down on that, you have the options of going into and using French or using Portuguese. So that makes this tool easily implemented within the different contexts that we have in terms of language abilities in our region. Then once you start to complete this tool, you have the date that you would want to populate and then the country. So if you go down to the cell that says country, all of the different African member states have been listed in this cell. Again, I would emphasize that this tool was created for the region of Africa. That's not to say that it couldn't be utilized in other contexts, but for this particular investigation and quality improvement aspect of IPC, the African countries are listed. There are 5 domains that are addressed in this tool. The first domain is the overall National Healthcare Worker Program. And as you can see under domain 1, a series of questions are asked in terms of your national program. If you wouldn't mind, Nancy, going over to the response box for question 1.1a, a drop-down menu pops up and yes or no responses are available for you to respond. If you respond no, you can see to the right, a score is automatically generated for you. And if you respond yes, a score of 8 pops up. Each question in this tool has a corresponding response and score that will be illuminated based on the response option selected. If you would, Nancy, just please go through and randomly populate the responses for this first domain. So as you can see, some questions are dichotomous, meaning they have a yes or no response. Some questions are multiple choice, meaning for question 1.1c, a question here is, what is the implementation rate at a healthcare facility level? So you would populate that using the percentages and the response options given. You can select any one at random, Nancy, thank you. And based on that, a score is automatically generated for you. For each of the questions, you would continue to do this and populate each question as you go. So questions in this domain are asking about the larger national program. Are there occupational health services? Are there social support services? What are some of the resources available in terms of the overall program itself? After you have responded to each of the questions in this domain, you'll want to move on to domain 2, which specifically emphasizes multimodal strategies to prevent healthcare worker infections. Question 2.1 asks you, at the national level, is there some platform in place to be able to procure and actually manage PPE and to avoid stockouts? You would answer this question as you had answered the previous questions, and a score will be provided for you like the other questions. Then you would move on to 2.2, and this is talking about guidelines and specific information that's available in guidelines to protect healthcare workers. Based on your assessment, you would go through and you would respond to each question based on what content is available in your IPC guidelines to keep healthcare workers protected from COVID-19. After you have completed each one of those responses and your scores have been populated, you can then move on to 2.3, which is talking about the specific availability of training materials for healthcare workers related to COVID-19. And under 2.3, you'll see specific individual questions related to training materials and training platforms for both health workers, auxiliary staff, and managers are asked of in this particular domain. If you can continue down, Nancy, I won't have you fill in each of the responses, but then domain 3 talks about epidemiological surveillance and assessments. There are two primary questions here, looking at the overall national strategy and the overall national program's ability to actually capture, analyze, and visualize epidemiological data. Question 3.2 then asks, based on the epidemiological data platforms available in country, are healthcare worker prevention measures taken based on the actual epidemiological data and the operationalization thereof? After you have answered those questions, you would continue on to domain 4, which is looking at strategic mechanisms in place for the early detection of healthcare workers at risks of exposure. You would go through, and 4.1 specifically looks at organizational detection. 4.2 is asking you about specific detection mechanisms. And then 4.3 is looking at, once you have those mechanisms in place, what are some of the recommendations around policies, specifically return to work policies around testing, laboratory results, and examination? Those questions can be answered under domain 4. Last but not least, domain 5 looks at how you are actually conducting investigations and managing those health worker infections that have been confirmed. 5.1 asks you for the actual system. Is it in place in terms of assessing healthcare worker infection risks? Are those cases that have been exposed and identified actually have levels at the healthcare facility to be able to assist them? What management mechanisms are in place? Are there investigation systems in place to be able to identify IPC gaps that created the exposure in the first place? And last but not least, it asks about the percentage of health workers that have been investigated. At the end of completing the 5 domains, if you scroll down, based on your responses to each one of those questions, a score will be produced. The score that we produced, based on the questions that we answered during this introduction to the tool, was 69. According to the scoring for this tool, that would be considered an adequate score. The interpretation of scores can be found in the box below. If we had completed this tool in its entirety, we would have gotten a different score and a different interpretation. If you can scroll down, Nancy, after you have gotten your score and you've interpreted your score, there's some brief demographic information about the referee or the individual completing this assessment to be captured in the box below. If you continue down, this particular tool provides you a quick visualization of the data and the responses that you captured. The first visualization that is produced based on the score that was yielded in the tool captures the individual scores within each domain. You can see the pentagon here captures, each point on the pentagon captures one of the 5 domains. Based on the scores and the responses you provided to this tool, each domain has been given a raw score. This visualization allows you to quickly look at the 5 domains and to see where there are some IPC gaps that may need to be assessed and improved upon to further ensure health worker safety and protection. If you continue to scroll down this tool, a second visualization has been provided in the form of a bar graph. If you don't like the pentagon, the bar graph here also depicts the same data and interpretation of that data as you saw in the first visualization. It's just a different way to represent this data. Either one of these data visualizations can be used to inform your overall healthcare worker IPC protection strategy and used to inform key stakeholders both at a government level and those working alongside you in the field to further strengthen IPC programs overall in the country. Thank you so much. I appreciate it. This concludes my portion of the training today. I'm happy to answer any questions at the end of this session. Thank you so much.
Thank you, Ebeth, for that elaborate presentation. I'm seeing people are excited and they really want us to share this document with them. So I think the message has been sent to most people. So Nancy, could you kindly share the next tool? So that is tool 2, risk assessment tool. Thank you very much. So for the health worker exposure risk assessment tool, this is generally a tool that is used at facility level. And as Ebeth has said, it's used when there is an exposure. So you want to identify what is the risk of exposure. Is it a high risk or a low risk exposure? Then it's used by health executives or referents, and it's used on a case-to-case basis. So the aim of the tool is to detect early infection, manage based on risk, and prevent spread of infection. While its main objectives are to determine the reality of risk and categorize it and inform on the management of the exposed healthcare worker, whether it's a high risk or a low risk healthcare worker. Scroll down, please. So those are the target audiences. So it's basically structured into 4 components where we define what a healthcare associated infection is. And also called occupational infection. So, and the part 2 is intended to determine the existence or not of a risk of contamination, while part 3 helps manage the existing risk by giving recommendations, and part 4 is dedicated to an algorithm which summarizes the interpretation of results. Okay, scroll down, please. Kindly scroll down. So for the tool, We have, for the tool, we have the interviewer's information. What is the date that was interviewed, the name of the interviewer and the phone number, and then we get the health worker's infection, the last name, first name, age, sex, and so on. And of course, the type of healthcare personnel, categorized as the auxiliary staff or the medical professionals therein. Forward, just scroll down. Then does the health worker have a history of community exposure? So if the healthcare worker has a community of exposure, then there's likely the infection was transmitted through the community, so we don't continue. But if there's a healthcare worker exposure, if it's not, then we scroll down to healthcare worker interaction. So just scroll down. So here we want to know the first day of exposure to a COVID patient and the last day of exposure, the name of the healthcare facility, and the level of healthcare facility. Was it primary, secondary, or tertiary? Then depending on whether a health facility manages patients with COVID or not, that is it a COVID treatment center, a combined center, or not dedicated to COVID treatment? Then what type of services are provided? Is it outpatient, inpatient, and the rest as listed below? The city, the country, and where just and were there multiple COVID patients in a healthcare facility? You will answer yes or no. And if yes, what was the approximate number of COVID patients in the healthcare facility? Then after that, we want to know the activities performed by the healthcare worker on COVID patients, okay? So here, basically what we are trying to find out is the risk of exposure. Did you have direct contact to a confirmed COVID? Did you have a face-to-face contact? Or were you performing an aerosol generating procedure? Scroll down, please. And if there is an aerosol generating procedure, which one in particular were you performing? Did you have a direct contact to environment? So we're looking at fomites as a means of transmission, mode of transmission, sorry. And any interactions with the paid or unpaid other healthcare facilities. Again, accidental exposure to respiratory secretions of a confirmed or probable COVID patient. So in this case, if you've answered no to all the questions, then you are not exposed to COVID, and so there is no risk. You're not at risk of COVID infection. However, if you've answered yes or a no to 4A to 4F, then you're likely exposed. So we want to know, while you were exposed, were you compliant to the IPC practices or not? So scroll down, please, Nancy. So next, we want to know about the duration period of a healthcare interaction with a COVID patient. And how you are using PPEs. So these PPEs have been listed below. Scroll down, please. We have the gloves, the medical mask, the shields, disposable gowns, and so on. And then we also want to find out, did you remove and replace your PPE according to protocol, the donning and doffing? And then during the period of healthcare interaction with COVID, did you perform the hand hygiene? So for 5D, we are looking at the 5 moments of hand hygiene. Scroll down, of which we know. So you will ask your patients the questions. And then we'll want to look at the adherence of IPC when you're performing an aerosol generating procedure. So again, we look at the PPEs that were used when performing AGP. So they have been listed there. So if a health worker answers always as recommended, that is, they were using the right PPEs, then they are exposed, but they are compliant healthcare workers. So they are at low risk of infection. But if a health worker does not answer always as recommended to one of the questions, then they are exposed and they are non-complying healthcare workers. And so these healthcare workers are at high risk of getting COVID infection. So what do we do about our low risk and high risk patients? Kindly scroll down, Nancy. So patients who are at high risk of infection should stop all healthcare interactions with patients for a period of 14 days after the last day of exposure to confirmed. Then for confirmed COVID patient, then they should be tested for COVID and get quarantined for 14 days in a designated setting. So for healthcare facilities, it means that they should provide psychosocial support, provide compensation for the period of quarantine, and have refresher IPC training for the health facilities. Kindly scroll down. So what are we saying in summary is that these patients who are, if you're having very many high-risk patients, then there could be a problem with your IPC training. So you need to go back on the ground and really train your healthcare workers so that you avoid creating gaps, the workload and issues of staffing can be addressed. So for patients with low risk, then they need to self-monitor their temperature and respiratory symptoms. We need to reinforce contact and droplet precautions, reinforce airborne precautions, reinforce the rational, correct, and consistent use of PPEs, and also talk about the WHO's 5 moments of hand hygiene and practice respiratory etiquette at all times. So if at the end of the information, basically what we're saying here is that this document comes with a caveat that at times you may have the healthcare worker is a low risk, but then there's community exposure. So then you need to also consider community exposure in these healthcare workers. And then also we need to identify occupational risks and investigations continued as per question 5 and 6. So this is just a simple algorithm that you can also use as an IAC material and have as a poster in your various healthcare facilities. So I think that is it from me. Gertrude, you can take over, please. So Gertrude will be sharing with us tool 4. So Nancy, if you could kindly share tool 4.
Can you see the screen I've shared tool 4?
Yes.
Yes, we can see your screen. Gertrude.
Okay, thank you very much, colleagues, for the opportunity to share with you this tool. As was indicated by Deborah, whilst tool 2 is for those who are exposed, this particular tool is for those who are actually positive for COVID. Please go down. It's very similar to tool 2, but this one is an expanded one that actually investigates, please hold on, okay, investigates the cause of the exposure and then the management of the healthcare worker. So the objectives as outlined here are to determine the circumstances for the onset of the infection.
Oh, sorry, misunderstood.
Determine the factors that facilitated the infection, identify the probable mode of contamination, which is the same, similar to 2, and also take appropriate measures based on the investigation that will be done. The purpose is also to inform epidemiological surveillance at a larger scale, locally and nationally. The target audience, as was indicated, this is also a facility-based tool, but the information can be used by all at the different levels of service delivery. Please scroll down. You can go down. Okay, so this particular tool is in 3 parts. Can you go up a bit? Up. Okay, yes. The first part, Nancy, you are moving too fast. Okay,
I'm at the
I'm
target
finished with the
panel.
target audience. Can you go to the different parts? Move down. Thank you, it's okay, yes. So the first part is mainly about the information on COVID, the definitions thereof, just as we had in 2.2. The second part is mainly about the information on the healthcare worker and whatever the healthcare worker was doing. And then the third part is devoted to interpretation of the results of the investigation that is carried out. Please move down a bit. Okay, so just as we have with the 2.2, we have the definition of COVID and associated occupational infections. The information is similar. Please, can we go down? Move down to the tool itself. Down. Thank you. Okay, so we have the about data. Oh my God. Okay, so this is interviewer information and the context information for this assessment. So we have the date, we have the name, and then the last name of the interviewer. The type of health facility that we are dealing with. The type of facility in the context of COVID, whether it's dedicated to COVID management or it's a mixed one or a non-COVID health facility. And then date of the specimen collection, because as I said, this one is for those who have tested positive for COVID. And then the previous test date, if any, you have to indicate it there. The reason for the test, there are options there for you to choose from. If you don't find the option for doing the test, then you can specify the reason for the test. And then 1F is to date how many healthcare workers have been tested in the same facility. If you have the data, you indicate it there, and then the test results, whether they were positive or negative. Can we move down? Thank you. And then you move on to find out information about the test. Are there areas dedicated to COVID cases in the health facility? Are there healthcare workers dedicated only to care of COVID-19 patients? The responses are there for you to select from. Move down. If yes, how many health workers are dedicated? These are information on the healthcare facility and the context. Now, the next section, which is 2, is on health worker information. That is the one that has tested positive. So we have the name, the date of birth, sex, city, country, contact details, and then the category of healthcare worker. This is very important. So you select from the options that have been provided. Please move down. And then healthcare facility unit type in which the healthcare worker worked, whether at the outpatient, medical unit, maternity, or any other point in the health facility, you select one. Date of communication of the test results, and then we move on. This is still the health worker information. So we want to find out in the last 14 days prior to the onset of symptoms and or day of the test, whether the healthcare worker have been in close contact with any of the following on the right side during working hours. So the options are there for you to select. It goes also in there 14 days prior to the onset of the symptom or on the day of the test. Have you been in close contact with? Also the options on the right side for you to select from. And then we also want to know, have you been surveyed for the risks associated with the exposure? Is a yes or no, and then we want to know whether when you were surveyed, you were classified as high risk or low risk, or no reason was given. We also want to find out whether the healthcare worker has any comorbidities. Please move on. The third section is on the health worker and the healthcare facility information. These are additional information to help us actually categorize the infection and the context very well. Date of the health worker first exposure to confirmed COVID-19 patient. If you know it, you state it. If you don't know, you indicate it. Also, date of last exposure to confirmed case, you indicate. Name of the healthcare facility where the COVID-19 patient received care, you indicate that as well. Please move on. So these are straightforward questions that we need to complete to help the investigation. Please go down. Yes, and then we also want you to indicate information on training that the health personnel has received on PPE and other infection prevention and control measures in the healthcare facility. For example, do you know the 5 recommended moments for hand hygiene? Just as we have in the tool 2, similar questions are asked here for us to understand your knowledge and skills in IPC and other preventive measures for COVID. Please, can you move down? Okay. The fourth section is looking at health worker activity performed on confirmed COVID patient. So we are interested in knowing what you were doing before you got exposed or became positive for COVID-19. So did you provide direct care to a confirmed case? It's a yes or no. Did you have close contact within 1 meter? We want you to respond to that. If yes, what was the longest period of close contact? And we all know the classification for whether you are a low risk or high risk depends also to a large extent on the duration of contact with the COVID positive case. Was the confirmed case classified as pre-symptomatic, asymptomatic, or symptomatic? The service provider needs to indicate this. Please move down. Can you move down, please? Similar questions that were asked on tool 2 will also be asked here, especially for us to understand the use of the PPEs. And similar PPEs are here, the single gloves, medical masks, respirators, whether you use them always, most of the time, occasionally, or rarely, is to assess compliance or adherence to IPC guidelines. Please move down. Okay, so 4.F, during the healthcare interaction in the COVID patient, did you perform hand hygiene? This is still about the IPC interventions and then preventive measures. Please move down. This whole session is about that. Please, can you move down, please? Yes, move down. Okay. And this component, this section is more about aerosol generating activities. We also want to find out whether you carried out any aerosol generating activity. And whilst you were doing this, did you take the preventive measures necessary for you not to be infected? So the questions are similar to the questions in tool 2. Can we move down to the next section? Thank you. Okay, accidental exposure to body fluids. These are also questions to ascertain whether you had any accidental exposure to body fluids or respiratory secretions. And they ask about specific incidents and how you were able to manage them. Can we move down? Okay. The difference with this tool from tool 2 is that we also want to know the impact that the COVID-19 infection has on the healthcare worker. So we'll be looking at the disease impact. Please, can you move? Hello?
Sorry, my apologies. I don't know what happened.
Sorry. Thank you very much. Okay, so we'll be looking at the clinical symptoms. We want you to give an assessment of the clinical symptoms that the client is going through, that's the healthcare worker. And then over time, the evolution of the disease. We also want you to make some judgment about it, whether the healthcare worker healed without without after effect, healed with after effect, or you don't know. If you don't know how the disease evolved in the healthcare worker, you indicate that as well. And then the next 7.C1 is looking at professional categories. Okay, so the professional categories are similar to the ones that we have in almost every healthcare facility, whether admission, reception desks, the professional contact, the ones that came into contact with you, you indicated there the number of sick leave staff on days. These are hospital or health facility data that will be collected in order to assess and facilitate the investigation. Please, can you move on? Thank you very much. So having done the investigation, this section helps you to make a good interpretation of the results of the investigation. So it helps you to take the necessary actions. So for example, the concept of the management of suspected, probable, or confirmed case. I'm sure every country has some guidelines on how to identify suspect, probable, or confirmed case. It also helps you to document correctly what has been done. The staff who have worked in the field which takes care of such patients are provided with the necessary education and guidance in order to prevent transmission of these infections. The B section helps to determine the enabling factors in the health facility that can help you in the management of the case. It also helps you to link individuals to performance measurement activities in the health facility, both individual and health facility wide, and also to link performance to established service charters and others that we have. Can we move on? Okay, so these are guidance information to help you in making your decision regarding what to do in terms of addressing the gaps that you have found based on the investigation. And then at the end, you provide a probable short-term preventive corrective measures that you think that should be put in place, both at the individual and health facility-wide level, to address the challenges that you have identified in the investigation. E is more about therapeutics and social care until the staff returns to work. And we have guidance documents on this in almost every healthcare facility. If you do not have one, then this is the time that we should start putting them in place. What happens if a patient or a client or the healthcare worker is at home, and what kind of support can we give them in order to return to work safely? Can you move down? think that's about the end of this tool. So just to add to this, I wish to indicate that the difference between tool 2 and tool 4 is that in tool 4 is for those who have tested positive, and we want to know additional information for us to be able to understand the disease, understand the context in which the infection occurred, and then also address, propose remedial action to address the infection in the healthcare worker. Thank you very much.
Thank you very much, Gertrude, for that enlightening presentation. So the next thing we will do is we'll look into the data management. And Andrew, you can now take the floor, please.
Okay, thank you very much. If you don't mind, I will also share my screen so you can see the presentation that I would like to intend to share with you.
That's
All
fine.
right.
You can share.
Can you see it now?
No, we can't see.
Just sorry. Screen 3. Can you please let me know once you can see the screen?
We can see the screen.
Thank you very much. All right, so my intention is really to share with you the various stages or the phases of the information management process and the various platform, the advantage of each of the platform that has been presented to you. The second part is just the various kind of details of which tool has which kind of platform. And the last one is a question and answer. So you can see from the 3 tools that you have previously that depending on the platform that you have, you may have multiple features. But in all cases, we would like to go through these 6 stages. The first one is to get the data at the source. So this is actually what you mean by the interview. And once this is done, then we do the data entry. From the data entry, you can already, in some cases, you can already perform some analysis, the initial conclusion. And then when you want to see the aggregation at the regional office level, or at healthcare facility level, or at national level, we need to aggregate this data. And that really may be a very difficult task according to the platform that you're using. Once you have the data aggregated, then we can perform the analysis and the reporting. With all of that, the 5 steps, then we can do the implementation monitoring and evaluation. So if you look at the Word file, the Word file that we have for the tool 2 and tool 4, it really helps us to do the interview. And of course, you tick in the data in your Word file with your ball pen, but you need to have another system if you want to put it in any kind of electronic format. And that is actually something that we can have with the Excel file that we have with the tool 3. Not only we have the ability to respond some of the questions, but we can also have some dynamic recommendation from it. As you can see at the end of the question, when Ebeth presented the tool 3, we have the chart, we have the graphics, which allows us really to have very immediate conclusion about the recommendation that can be done once you fill in the various questions. But with the Excel file, you have it for one specific country, which is okay. But when you have to have multiple instances or multiple Excel files, then you need to have an additional work to get the data aggregated. And this is actually the advantage of the COBO, because the COBO allows us not only to have some selective question displays, means that if we say that, are you exposed to any kind of some contact? If you say no, then there is no question, follow-up question. But if you say, yes, I was exposed, then a set of new questions will appear automatically based on the question, yes. And similarly to the Excel file, you can also have at the end of the COBO some kind of conclusion based on the response that you have provided. But in addition to that, selective question display on the risk conclusion, you may also have automatically the data aggregated, because all the questions, all the response are saved in the same database. And at the end, actually, eventually we can create from this data a dashboard where we can see the analysis, we can analyze the result and see the trend. The second advantage as well is that when you have the data from multiple countries, we have the possibility to export the raw data, and we will share it with the country office IPC focal point, who can do further custom analysis if the dashboard is not really enough yet. Based on that, actually, then so far, if you want to have some kind of reporting, there are some additional work that needs to be done. And the same for the monitoring and evaluation. So at least the package that we have so far allows us to cover, if the country uses the COBO, to have the interview session supported, the data entry done with the people with the COBO, and the aggregation automatically completed. And then, of course, we already use the dashboard for some of the other tools that we're using for the IPC. As you can see, currently we have the COBO available for the tool 2 and the tool 4. So this is really what we have currently. So if I come back to the tool that we have for this health worker infection protection, we have for the national policy assessment, tool 3, we only have it on the Excel format. For the tool 2 and tool 4, we have the paper version. And this is what Deborah and our colleagues shared in the paper version, but we also have the electronic version as well available for these two tools. I've already shared with you what are the features of each of them. And at least one, the fact that if should there be a need to change or to update the tool, with the Word and Excel file, we have to make sure that all the people who are being assigned to use the tool, they get the new version. So we need to go through the distribution hierarchy to make sure that everyone has the latest version. But in the COBO, should there be any needs to change, we just change it at central level online, and then that it can be applied. It can be applied when people connect to the COBO, then they will have automatically the latest version. I think this is what I would like to cover for my section. So I think we have the room for all the questions and answers now. Over to you. Thank you.
Thank you very much for the presentations.
Yes, now we can.
Thank you very much for the presentations. They've been really, really good. And we've learned about the tools that WHO has. There are several questions on the question and answer. And maybe one of them that I would like to ask the panelists is with regards these tools, are these already implemented in Kenya, and where are they being used, assuming they're being implemented here? Or is it something that is a pilot and will be implemented in the near future?
Okay, thank you very much, Nancy, for that question. So the reason why we had this meeting today is that we are not having the response from Kenya with regards to implementation of this tool. However, we are at par with what is going on at the Ministry of Health level, CDC. We know a lot of research has been done with regards to healthcare worker infection by CDC and other partners. And we know that really analysis is going on as to the contributors of healthcare worker infection as well as the facilitators. However, these tools have not really been incorporated in our setting in Kenya. So the reason why we actually had this platform is to sell the idea, the importance of these tools in terms of risk assessment, surveillance, as well as carrying out a national IPC capacity. So with this platform, we really would love that the tool be implemented with support from us, from the regional office, as well as the hub, so that we can really look into the contributors to healthcare worker infection and improve this in the setting.
Thank you very much for that response. There's a question here from Macduff Ogwido. In terms of the filling of tool 2, which is for suspected healthcare workers. So the question is, at any time for filling the tool, since exposure does not, is there like a time limit for filling the tool? Since exposure does not always lead to infection, is there monitoring for example, 5 to 7 days? I'll combine this question with a question from another attendee. So what happens if there's a reinfection? How do you feel in that too?
Okay, I will answer the first one because I'm aware of what she's talking about. Now, you see, the thing is, you're looking at risk exposure. Is the healthcare worker a high risk or a low risk? And I know there's a study that has been done in Kenya by CDC where they showed that most patients who are high risk patients were likely to turn out to be COVID positive. I think it was around 80% or so. They were actually there was a higher chance of turning positive. I don't know if Lioness is in the group with us today. And so this tool is actually trying to categorize. It's a risk assessment tool. So we cannot say that there's a time limit. Whenever you're exposed to a COVID patient, then you want to know, categorize the healthcare worker. And thereafter, as you can see from the presentation, there's a monitoring, there are the recommendations which include monitoring for respiratory symptoms and temperature, among others, as well as training and other recommendations have been offered. So I cannot say that there's a time limit. This is something that needs to be carried out routinely so that you can really evaluate for the risks of infection. Thank you.
So there's the other question in terms of what of a reinfection? How is this tool to be completed?
Okay, maybe I'll take that one. This is Gertrude.
We can hear you.
Yes. Okay, so as I indicated, if the healthcare worker is tested positive, that is when we use the tool 4. So the tool 4 actually does it goes in deep dive into the investigation as to what caused it, but that doesn't mean that the healthcare worker will not be managed. The healthcare will be managed according to the COVID-19 guidelines of the country. I also want to indicate that this system, as a matter of importance, should be incorporated into the occupational health and safety program or mechanism that exists in the country or the healthcare facility. So for example, in some other countries, once a healthcare worker is exposed, there is a place, a dedicated place or a program or a section in the healthcare facility or a zone that they are expected to report to. Having informed their supervisor that they are exposed, they go to the dedicated section where they are actually now assessed to determine the level of the risk, whether it's low risk or high risk. Once it's determined as low risk, in many countries that I have experience in, low-risk healthcare workers are expected to go back to work. They do not go on quarantine. It's those with the high risk, as you saw in the tool 2, that are expected to go on quarantine and are monitored for the 14 days. However, if during the assessment you are already infected, you are positive, then you'll be managed according to the COVID-19 guidelines of the country. I hope this helps a bit.
I have a question, Nancy.
Yes, that's okay. You can ask a question.
Yes, my name is Professor Ndwati. I have a question. Now, COVID-19 is a strange disease in that you're most infectious before you're even symptomatic. And so that health workers will probably be exposed to people who we don't even know that they are actually infected. The experience, particularly like in pediatric wards, is that you have children who come in and 2-3 days down or several tests down the road is when they turn up with a positive test. The second, and because of this nature of in our population, up to 90% people being asymptomatic, then this too, in essence, does not really capture the exposure. It does not capture the challenges around IPC. I wonder whether in your thinking through whether the monitoring shouldn't be regular monitoring of whether health workers are following standard IPC procedures and not waiting for when somebody thinks that they've been exposed. So sort of like periodic observation of staff in all areas of the hospital. In the middle of a pandemic like this, this too will work very well for what is a designated COVID unit. But most infections, if things are running well, are not going to come from a COVID unit. Most health worker infections are not going to be at the COVID unit. It will be in the rest of the hospital. And so the need for sort of like a process evaluation, a regular process evaluation as the way to improve IPC and to protect health workers. And then my second question is to ask, has this tool, okay, this tool looks like it's been developed for the Africa region. Has any country implemented it, and is it working? And what are they using in the context of where they've had very bad outbreaks, like in Europe today or North America? Thank you.
Thank you very much, Prof, for that question, for the two questions. I think I would want to take the first one, but I think I'd want Prof Babaka to answer the second question with regards to piloting and how they came up with the tool. So I think the importance of this tool, like, it's not only in the COVID treatment centers, but it's all over, because it's able to, it's a risk assessment tool. That is the tool to, it identifies the risks and the adherence to IPC practices. And so whenever you get, like in a healthcare facility where most healthcare workers are scoring highly or they are high risk healthcare workers, then the challenges there need to be addressed. Are there issues of inadequate PPEs, issues of donning and doffing, hand hygiene, and so on, which have really come up time and time again? Because when you look at our countries, there are certain healthcare facilities where so far very few healthcare workers have been infected with COVID, yet others have frequent infections. So you wonder, why is that so? Is it that they are not adhering to the IPC measures that have been laid out? So I think it's an important tool because it looks into the risks as well as adherence to IPC. Equally, we have early recognition, and we advocate for early recognition as well as screening. And observatory studies are also recommended by WHO, that is looking into the issues of hand hygiene and so on. So those are strongly recommended, and we are monitoring that from our national and international level, but we really want this to come out also at the facility level so that we can prevent infection. I don't know if there's anything else to add, but I wanted Prof. Babaka to talk about the implementation of the tool and the pilot studies. Prof?
Thank you, Deborah. Unfortunately, even in the pilot countries, they don't start using this tool. It is the reason why we have elaborated the approach in 5 steps for guidance to countries on how approach to be used for implementing the tool. It is an approach recommended by WHO in 5 steps, and I said in my email that we didn't present this approach of 5 steps, but it is very important because it can guide countries on how to go for implementing the tool. Because in many countries in Africa, they want to implement it, but they are not starting until now. I don't know if I have answered the question, but sorry, my English is not very well. I would like to add something about
Hi, Prof. We can't hear you. I'm not sure whether you
will capture all infection in your facilities, all the infection, even asymptomatics, because for screening, for testing, is here to capture all infection you didn't capture with the tool 2 or 4. Over to you.
Thank you very much, Professor Babaka. We're almost coming to the end of this session, and there's a question here from Maurice Aluda. So the question is, currently in Kenya, we are using the Jitenge app for healthcare workers' COVID infection. So will the combo app by the WHO interface with the in-country tools, or will this now be a separate tool that will be required to be filled?
Let me add to that. And maybe WHO needs to see what we are doing, how the Jitenge app is working, and maybe that might also contribute to an improvement into the tools they are proposing.
Thank you very much. I think, Andre, you will take up the question.
Okay, thank you very much. Usually, actually, as described in one of the slides presented by eBeth, when the country decided to adopt the tool, there should be first a discussion that needs to be done about, okay, what about the tool and the integration and all of that with which platform and all of that they would like to use. I'm not aware of any discussion that is already happening between Kenya Ministry of Health and WHO in terms of the tools. But so far, I'm not involved in any discussion about the integration of the two tools. I'm more than happy to see what is done in Kenya in terms of COVID. However, I just want to inform that when we do these tools, actually, it's not only for a specific country, we do it for all the countries that we are supporting. So we try to ensure that we cover at least the minimum needs that we think is really required for all the countries. Of course, if some countries, they decide to have their own other tools, we are more than happy, because we convinced that that is the most important is really to control these COVID infections. So we are happy that other tools are available for that purpose as well. So what we have is that we definitely have the possibility to export the data from the COBO and to export it in an Excel, and that can be reused if with the national system, should there be a need to integrate the two tools. Over.
Thank you very much for that response. A lot of the participants are requesting whether they could have access to these tools. So assuming one wants access to these tools, where can they get them?
I think it's also Andre to answer that, please, Andre.
Okay. I think they are, again, the same as I have presented presently, just previously. These tools should be used in the context of a national policy. They are not just tools that work independently from one to another one, because there is really a need to have a national policy that needs to be done. So of course, they are available. We already share them with all the focal points on the people participating in the IPC networking, which are WHO staff, but also other stakeholders who are actively working on the COVID in the fields. And we already share the links, and they are available according to what you can see in the PowerPoint presently. But again, even if they are accessible, there is definitely need to have a kind of coordination at the national level with the Ministry of Health in order to make sure that that has some impact. Because if it's only one person who are using it, it does not, I think, have the same impact at the national level. Over.
Thank you very much. We are beyond our time. So maybe I'll give the presenters a few minutes to give the parting shot. And I'll also give Jane Claire Mudhoni and Abigail Moembu to say something even as we close. We can begin with Jane Claire Mudhoni, then Agnes Moembu, Abigail Moembu, then we can get a parting shot from one of the presenters, even as we close.
Good afternoon, everyone. I hope you are able to hear me. Hello?
Yes, we can hear you properly.
Jane Claire, you're muted.
So sorry for that. What I was saying is that we are happy to hear about your concern and to learn about the tools that can help us evaluate on the staff's infection of the COVID-19 and the source of infection. As for the practice, I can talk of the Kenyatta University Referral Hospital, which is the largest Kenya COVID managing center, that we have had quite a number of our staffs having COVID. And actually, we didn't have a tool of evaluating on the courses or to have a data on how or of the probable places where they could be getting the infection. However, the tools that you've presented are quite helpful. But my concern would be, since the tools are all new to all of us, how maybe Dr. Babaka, you can tell us how you did the pilot study and how effective it was during the pilot study. And is it possible that with these tools, you can give us time to evaluate by doing a pilot study ourselves to our country? And are we able to customize it, or do we have a platform where we can be giving our inputs? Thank you.
Can I answer?
Yes, you can.
Okay. As I said, the tool are for all countries, even the pilot countries and other countries. The difference between pilot countries and the other countries is only that will help pilot countries with financial and maybe in human resources.
Yeah.
So even in pilot countries, they do not start, they not have starting the use of the tool.
Okay.
The reason why we have proposed an approach on how to go for implementation of the tools.
Okay.
Different steps.
I'm sorry, your sound is a bit poor. I can't really get you from my end.
So I'm speaking very loud.
Prof. Babaka, I think you're breaking up.
Okay, it's about.
Maybe you could proceed.
I'm speaking very loud.
Maybe you could proceed to the comment from Abija Mwimbo, and then if Prof can get.
Do you hear me?
Okay, good afternoon, everyone. Thank you very much. My name is Abija Moembu, an IPC coordinator from Kenyatta National Hospital. I want to thank WHO for this good effort that they have put across. And I think I like the tools. And just like my colleague is feeling, we need to know how we go about implementing these tools, because they seem to be helpful, though we have not just been silent. Like, we had our small tools that we were able to capture the exposures from our staff. And I think we can incorporate this into the tools that we already have, and kindly let us know when we can pilot and how we can go about it. Thank you.
Do you hear me now?
Yes,
Yeah, we can hear you.
I was saying,
yeah,
the tools are for all countries, pilot or no pilot. The only difference between pilot and no pilot is that WHO provides some fund to pilots for implementing the tools.
Okay.
But we mark that even in the pilot country, they do not have certain implementation. and how implementing the tool. The approach using 5 steps, and it is available, and we should present it to you.
Hi, Prof. You're still breaking up, and we cannot hear you.
What is the problem?
In the interest of time, maybe you could give. Yes.
I think
Yes.
I think what is the two ladies from the statement from KNH and also the statement from the Kenyatta University is that the tools look interesting, but Kenya would want to pilot them, look at them, and panel beat them to fit into our situation. I think that's what we're saying, that as a country, there may be challenges of adopting wholesale the tool without actually taking into account local realities. Sure. That's what I'm understanding the statement, because it's the reality is that some data, there's some work that has been going on. There's data that is being collected. So there would need to be some interfacing. And I think the discussion now should be, if this tool is available, how quickly is it available? We are almost well into us, sort of like the next peak with in the city of Nairobi, and we're also having growth of this pandemic all over Kenya. So if we're going to use this tool, it needs to be in place like yesterday. It's not this thing that we'll wait until whenever for it to be done. That's my observation. We already have some a work around IPC and health workers. For example, needle stick injuries are reported. Hospitals have systems for doing that. So there's already somewhere to sort of latch on and get the work going. So the question is, if we are to take it up, how soon and how does it merge in with the work that's already going on in Kenya? Thank you.
Thank you very much, Prof. So I think the next, the way forward is that we will have a smaller meeting with the group in Kenya. That is our WHO IPC focal point, as well as our Ministry of Health counterparts, where we will sit down and look at offer some technical guidance in terms of implementation of this tool or complementing the tool that you have. To suit the kind of setting or environment that is there. And so we have really heard of this Jitenge app, of which a lot of compliments have come from it, and we would love to hear it more. So from this small group, I think we can take further discussions forward and hopefully have the tool implemented in the country.
Deborah, it might be that WHO might want to pick up Jitenge app as the Africa tool. So let's not assume it's only one way traffic, yeah?
Yes,
yeah?
yes.
Because it already it's already on ICT platform, which allows then for the central Ministry of Health to communicate very effectively with the counties. Far-flung places can report very easily. So I think the technology is a bit ahead here in Kenya, so maybe it might be the other way around in terms of interaction.
Yes, yes. So we'll discuss that with the group, and I hope we'll have someone from who was designing this Jitenge app, so that we can learn more from them. Thank you.
I say something very quickly. Do you hear me now?
Yes.
Okay.
Yes, Prof.
Yes, we can hear.
I just want to say that for the tool tree, as I said in the beginning of the training, we are going to make some changes very soon. And I would also like to tell that I don't know why Kenya is not using the tool, but they can use it. They can implement the tool using the 5-step approach. And the pilot countries we are going to say, but they don't say, they don't. And also, finally, each country will have on his own royalties. Over to you.
Thank you very much for this presentation, and it's been a really interesting presentation where we've been looking at the technical tools for healthcare workers, and all the input I think has been noted and the questions have been answered. For anyone who has queries on CPD points, kindly email us at knetcpd@gmail.com, and we'll be able to address any questions and concerns that everyone has on concerning CPD points. We are a bit over time. Thank you very much for your patience for all the attendees, and do have a blessed evening. Thank you.
Thank you.
Thank you very much, Dr. Nancy.
Thank you, Nancy. Koheri.